We have published a couple of years ago some international recommendations how to treat those patients, and in parallel we started a registry which is a European registry under the umbrella of the Breast International Group, and where we are collecting data of those patients in a retrospective and in a prospective fashion. As you all know, breast cancer is the most common disease of women, and it's about 1/3 of all cancers in the premenopausal patients. We expect that about 1% of all breast cancer patients are at their diagnosis confronted also with a pregnancy, and therefore they have to make the decision to continue to stop the pregnancy. The MD Anderson has also developed in a prospective fashion a protocol how to treat those patients with chemotherapy during pregnancy, and they start after finishing the first trimester and treat them with a standard chemotherapy. The survival rates, which has often been compromised or is thought to be compromised in those patients, is actually not, because I personally believe that the data you have are conflicting because the patients don't get the right treatment during pregnancy, and therefore they might lose out at this point. The primary endpoint of our data collection is actually the fetal outcome 4 weeks after delivery, and we have a couple of secondary outcomes concerning the baby and the outcome 5 years after delivery and of the mother. And we also want to collect data from the tumor, and we want to know how the patients get treated, get diagnosed. The recruitment from the beginning of April was 141 patients from 59 centers actually, and from 10 countries throughout Europe, so it's really a pan-European registry now. Here are some data. It's a bit difficult for me to see that, but you can see that 20% of all patients have been diagnosed in the first third or the first trimester of the pregnancy, but the majority, of course, has been diagnosed during the second trimester, when it's the easiest to treat those patients, and about a third in the last trimester. The median age of delivery was 37 weeks, and normally you deliver a baby around 40 weeks, so it's just a bit, the range is between 31 and 41 weeks, so actually quite normal. The median weight of the babies is 2,740 grams, which from the patients who received actually chemotherapy during their pregnancy. And the median weight of the babies whose mother did not receive chemotherapy during pregnancy, the weight was actually almost the same. So we had no compromise during this treatment, through the treatment in terms of the weight of the babies, and this APGAR score, which is measured 1 minute, 5 and 10 minutes after delivery. It's a clinical score, was not different between the babies whose mother did receive chemotherapy and whose mother did not receive chemotherapy. Here are the different regimens which have been given during the therapy. On the right side, the CMF is actually not recommended, but it's a retrospective trial, and so there are older data in this registry as well. We recommend to use anthracycline-based therapy, like on the left side, ACEC or FEC.
So it's important to see that you can give optimal treatment while patients are pregnant, and I think that's the most important. Without apparent problems for the child, and I think that's the one important message.